right, we're going to go ahead and get started. So I'd like to welcome everyone to today's event. We're going to be focused on remote patient monitoring. We're going to learn, engage, and advance RPM. And we're really excited to have everyone in attendance today. Before we get started, I'm going to review a few Zoom tips. Everybody has been muted on entry. Thank you. We are going to encourage you, though, to use your video, join with us, hang out. It's going to be a fun day, so please be on camera. We're going to ask that you use the chat and the Q&A function as much as you can. Please ask your questions at any time. Chat with us if you have any thoughts or feedback you'd like to share. Also, we want to let you know that the event today will be recorded and we will make the materials from today's session available within the next week or so. And an email will go out to all the participants who registered with that information. So you will be notified when that is available. Next, we want to share, this is a CTRC event, and CTRC does not have any financial interest with any of the services or products that may be discussed in today's event. We're not here to share legal information, we're just here to share information. And once again, this event will be recorded. So thank you. This is our agenda for today. We have a lot to cover. It's going to be a fun, full day. We're going to kick off with a welcome from CHCF and CTRC, our event hosts, and HRSA. Then we're going to flow into a policy panel with great insights into policy challenges and implications for remote patient monitoring. Then, of course, we got a break. It's a long day. Everybody needs a break every now and then. Then after our break, we're going to resume with some subject matter experts in the field of remote patient monitoring, hearing from real clinical experts who are actually doing the work. We're going to learn from them. And then we're going to ask you all to chat with us in some breakout room discussions and share how we can support you and what next steps you'd like to take. And that's our day. So now I'll hand it over to Diana to share a little welcome from CHCF.
Thank you very much. Welcome to today's remote patient monitoring event. We're thrilled to have all you innovators and learners with us today. And I know it's a long day, but the goal here is to go deep and to learn and to share together. I'm Diana Camacho. I'm a senior program officer at the California Healthcare Foundation. I lead the foundation's work on telehealth. For those of you not familiar with CHCF, we are a not-for-profit foundation focused on improving California's healthcare systems for people experiencing low incomes, and we have a specific focus on the Medi-Cal system of care. CHCF has focused on telehealth for over a decade as a means to increase access to care for vulnerable populations. Since the start of the pandemic, we have really doubled down to ensure equitable access to telehealth, and we do that by making investments in a few areas. First, in the delivery system to scale the use of telehealth. We also invest in policy to advance coverage and payment, and we advance in data and research to foster innovation, learning, and transparency. I think we can all agree that the pandemic has changed how healthcare is delivered, namely through telehealth, where we've recently had some really huge wins. For those of you in California, we know we have new Medi-Cal telehealth policies that have made permanent the broad flexibilities and payment made possible during the pandemic. We also know that people continue to like and want telehealth. In an upcoming CHCF research publication, we talked to low-income Californians about their telehealth experience, and we really learned that telehealth has empowered patients by removing those structural barriers like transportation and taking time off of work, and really helping them to access care and build trust with their providers. And as a result of these policies, patient preference, and the hard work of the delivery system, telehealth has really stabilized a significant share of care being provided, especially in the California safety net. CHCF has been collecting data since before the beginning of the pandemic, and we are seeing that currently about a third of all primary care visits and 2/3 of behavioral health visits at a sample of FQHCs serving over 1.3 million patients are being delivered via telehealth. So that's a lot of healthcare. As we bridge to the post-pandemic world where telehealth will remain, I think we really need to take advantage of this momentum to innovate new tools and approaches. And I really think one of those areas for innovation and opportunity is remote patient monitoring. I think, as we all know, chronic conditions chronic care conditions really risk overwhelming our healthcare system if we do not find new strategies to manage them effectively. And this is particularly true for the delivery systems that I focus on and work with in the safety net, who care for a disproportionate share of Californians who have chronic illness, while also lacking resources and enduring kind of what we're seeing as a crisis in workforce right now across healthcare. And as I think you all know, remote patient monitoring really empowers patients and creates stronger linkages to providers. With all the opportunity that RPM presents, we all know that it can be challenging. It can be to make the case for it, to implement it, and to sustain it. So that's why we're here today, to go deep on those topics. There are a lot of organizations piloting RPM, especially across California. Today, the goal is to connect you all, the innovators in the space, to learn from one another so you can tackle your RPM challenges, whether you're just starting out or if you're looking to scale. So I want to thank the California Telehealth Resource Center team for putting together a wonderful agenda you all have today. I want to thank all of our expert presenters that are joining and all those doing the hard work. And most of all, thank you to our participants for leaning in, to engaging, and being here today. Thank you very much.
Thank you, Diana. Great summary. Next up, we have Lindsey Haase.
Thank you, Aislinn, and thank you, Diana. I actually want to lead in and really take a moment to thank the California Healthcare Foundation for their sponsorship and support of today's event. It's because of committed community organizations and nonprofits across the state of California that are interested in investing in the future of California's healthcare system and having these opportunities for us to convene and discuss what's emerging out of the technology to better serve our patients across the state. And it is with a full heart and gratitude, Diana and the California Healthcare Foundation, for making today possible, and the follow-up and the healthy discussions we will be able to have on remote patient monitoring. I'd like to share with you a lot of information on who the California Telehealth Resource Center is, but I will not read these slides to you. These will also be available to you after today's event, as well as our website is consistently and regularly updated with the latest and greatest information. So this will be a leave behind for you all as well as you move forward. So who are we? The California Telehealth Resource Center was founded 17 years ago. If you can believe it or not, we've been around for a very long time. Who we are is an unbiased, no-cost telehealth resource and consultative support service, mainly funded through the Health and Resources Services Administration, who funds the regional telehealth resource centers across the country. We serve all 58 counties in California, and we also collaborate and partner across the country to ensure that you have the latest and most helpful information available to you as you implement telehealth strategies and tools and technology. If we can go, yep. This is really who is the California Telehealth Network, which is our parent organization here in California, focusing mostly on opportunities to provide better access to broadband and other technologies that enable telehealth. The California Telehealth Resource Center is a program housed under the California Telehealth Network, and as I mentioned previously, is funded predominantly through HRSA, but we have partnerships that make special events like today possible, such as the California Healthcare Foundation. If we can go to the next slide, this is our amazing team that serves California as the California Telehealth Resource Center. My esteemed colleague, Kim Kleppinger, who is our president of the California Telehealth Network. We have Shubha Devadas, who is an amazing program manager and manager of our CTRC. We have Aislinn Taylor, who is hosting and facilitating us through today's event, and Mariah Getch, who is a fantastic intern and deserves recognition for her contributions to our program as well. So thank you for the team for all of your heart that's gone into today's event. We can go to the next slide. We like to tell you a little bit about what we are doing. So we have served over 17,000 individuals since the year 2019. And a lot of that is through the COVID pandemic and the rapid implementations of telehealth that you all have gone through. We, as I mentioned before, serve all counties in California. We host many workshops. We have monthly office hours and additional toolkits and educational resources. Since December 2019, in addition to serving the 17,000 individuals, we have provided over 2,500 hours of training and technical assistance at no cost. And we are seeing the sustained increase in the demand for virtual health services. So similar to what Diana was saying, California is hungry for this. They want to see it be used. We want to make the best use of our resources. And the data we have is just supporting that every day. And if we can go to the next slide. So I did mention a website. You can see it in the bottom left-hand corner, caltrc.org. We have a wealth of information that we maintain and update for you all, and sometimes create our own content if needed. And specifically, we are pointing you to a webpage on remote patient monitoring, and there's a toolkit. So if you have a moment, check out our website, download what you like. If we don't have what you need, our contact info is there to reach out, and we will connect with you shortly. And here is our contact information just in case. And we can go to the next slide. And that might have been my last slide there. So I'm going to turn it over to, I don't know if it's Aislinn or Mariah. There we go.
It'll be me. Thank you so much for that introduction, Lindsay. I really appreciate it. Up next, we have William England, and he is the Senior Advisor for HRSA, the Office for the Advancement of Telehealth. All right, over to you, Will.
So let's see. Yeah, you're all hearing me okay? Great. Okay, so go ahead if you want to advance the slides. Yes. So again, thank you very much for inviting me to participate in this event. We're certainly delighted to have the California Telehealth Resource Center, one of our 14 centers, focusing on remote patient monitoring. Each of our telehealth resource centers have various interests they work on. Two of them are very specialized, and I'll talk just a moment about that. But each of them have various areas of expertise. And in the world of RPM, which is relatively new in terms of the exponential growth taking place, I'm really glad that CTRC has interest, and hopefully will be providing good technical follow-up to this conference, as you were just invited if you have further questions. The Office of Advancement of Telehealth is relatively new to this area. We have been around for more than 20 years funding grants in telehealth, but the concept of remote patient monitoring, even though it's been around for a long time, is not something that we have been funding. Our first awards in this area, in fact, were in 2022. And that project is now finished its first year. And I was really hoping I could have some really pithy statements that we've learned, but they're not available yet. So I have no data from our own programs that I will be able to talk about. But the Office of Advancement of Telehealth is about all things telehealth, not only about giving grants, but also we serve as sort of a policy advisor to the Department of Health and Human Services on all things telehealth. And this, again, is one of the new ones and one of the really important ones. Next slide. So we take a very broad view of what is telehealth, unlike CMS, and I suspect a few CMS colleagues might be on here. I invited a few of them. We don't pay directly for services. So we can take a very broad view of telehealth without having to fit it into an appropriate reimbursement category the way my colleagues at CMS must do. So this is just one of the things that we are doing, but one of the more exciting new things that we're really jumping into. Next slide. And as I said, 14 telehealth resource centers, 12 regional serving all states and territories, 1 national center on policy, 1 national center on technology. So I can't imagine you're on this webinar and you're not already aware of them, but do take advantage. And I think we now know specifically for RPM questions where you may want to go, but they're also excellent at sharing their subject matter experts throughout. So if you ask one center and they don't have an answer, they'll find somebody at another center that does. And in fact, they're really our field agents, our army of experts. Most of what I know about telehealth, or much of it, I've learned from our Telehealth Resource Center experts, and you'll get to hear from some of them today. Next slide. So I just mentioned that California, or the Center for Connected Health Policy, is our policy center, and they certainly are a good place to go to learn information on policy, which is very important as we begin more and more work on RPM. Next slide. This is our one project. We do have our evidence-based telehealth network program is now jumping somewhat into remote patient monitoring. This is our first effort at direct-to-consumer telehealth, and some of the grantees are focused on RPM, but that wasn't a requirement, so it's not at all universal that they're touching RPM, but some of them are. Next slide. RPM has been around for a long time, and again, I'm preaching to the choir here, so I apologize. This is not an area which I knew a lot about. I've done some research to get ready for this presentation. And in fact, I've got a lot of slides and there's a lot of kind of dense material. I did that because in getting ready for this and the research that I put together, I thought, well, there may be people that are very familiar with RPM, but also some providers and folks that are new. So as I research and find useful things to read, I thought, well, I'll just throw those in as a reference. So you'll have the slides afterward with lots of websites that I stuck in so you can follow up as you have time. So back up just one sec. By 2018, we had enough RPM studies going on that in fact, a meta-analysis of RPM could take place. This is really before CMS jumped in full force to reimburse RPM. And in fact, RPM was very much the focus of hospitals wanting to avoid penalties for readmitting patients out within 30 days. So they were doing RPM simply because it was in the hospital's interest, even if it wasn't directly reimbursable in some cases. So this was an early paper on demonstrating, hey, it really is working. Next slide. So another thing I want to emphasize is a resource that we have put together as essentially as a result of the pandemic is telehealth.hhs.gov. This is all things the federal government would like people to know about telehealth, and we work really hard to curate this website with interesting and important information from the federal space. You will find a lot of references to TRC documents in here because, as I said, they're the subject matter experts. So as they develop materials, we want to make them available here on best practices. We initially stood this website in May of 2020, just as the pandemic was starting. It had a patients and provider side, because those are the two groups that suddenly needed to learn about telehealth. We've since expanded. There's a tab for researchers, a tab for funding opportunities, a tab for events, and a pretty good search function to find things. Next slide. So these are, in addition to patients, too, that you may want to look at upcoming events. This program is mentioned on February 9th. The funding opportunities, I used to always tell people, go to grants.gov if you want to know where to find money for telehealth. But we have been watching grants.gov and any other source we know where material is. So if you only have time to check one thing, you might want to be checking our funding opportunities if it's only telehealth you're looking for, because we are looking at grants.gov as well as other things and trying to highlight you should look at this program. It offers funding opportunities. I unfortunately will say in 2023, the Office of Advancement of Telehealth has no new money for new awards. So I hate to say that my own office, in fact, will not be making new awards in 2023. So look to us next year for 2024. We'll have some new programs and new funding opportunities coming out. We're just trying to maintain everything we have right now. Many of our awards are 3 to 5 years. So the way the cycles work, we just don't have any new things coming out this year. Next slide. So I went to our site, and I hadn't actually done this before preparing for this conference, and searched on RPM and our search tool, and son of a gun, I found a lot of stuff. So do that. And these are best practice guides and things that we have assembled that people need to know about RPM. In particular, the billing and payment, which we'll talk more about later today. We have a whole section and references on that at our site. Next slide. I mentioned CCHP, Center for Connected Health Policy, one of our telehealth resource centers, the Policy Center. A lot of the activity in RPM, which is a little harder to track, is going on in Medicaid programs. So mostly I'm going to be talking about Medicare because that one's a federal program, easier for me to report on, but Medicaid is really, really important. And CCHP has a guide for what is known about RPM in each state, and you can click on the little octagon or hexagon, whatever, and see what your state has. And you'll find pages of material on that they have assembled. Next slide. And in particular, reimbursement, which is really what's driving this huge growth in RPM, is the fact that CMS has now implemented on Medicare side reimbursement. But again, some Medicaid programs are already into that. And as a result of the pandemic, a lot more are. So you can click in particular to learn about reimbursement tools. Next slide. Just some useful references on RPM policy that I took a look at to sort of understand what are the issues and what are the future issues that we may want to be paying attention to in RPM. Next slide. Some of the uses of RPM, again, I mentioned historically post-operative care and follow-up. Where was the main use of RPM funded largely by hospitals in their best interest of keeping people from being readmitted within 30 days, which would hurt their reimbursement when they didn't really need to be. And then diabetes became early on also a program for RPM, careful monitoring for diabetics, and especially things like gestational diabetes, where this is not a long-term diabetes, but someone where diabetes complications can be very severe. Programs started doing gestational diabetes monitoring, but it's now expanded into so many other new things. COPD and hypertension, those are pretty obvious. Fertility management, that's I think a pretty new one. Chronic heart disease, and even acute conditions may be amenable to RPM monitoring. Next slide. So a large jump took place in 2020 as we all went home and had to get care at home. The proliferation of devices at home that would connect you, RPM type devices, absolutely took off. It continued in 2021. The exponential growth is projected to be declining now, but still staying at a pretty significant level. And this is bringing a lot of technology into the field. A lot of manufacturers are looking at RPM as the growth area now that providers can get reimbursed for RPM activities. There's a lot of technology folks that are extremely interested, and the big box stores are selling stuff that is literally clinical quality that they want you to buy to be able to monitor yourself and provide information to the health system. Next slide. And just some things I found RPM in the news back as early as 2011, cardiac monitoring was taking place, not with a Holter monitor, but with Band-Aid like strips that you could put on that would monitor your ECG and send information in through Bluetooth. Of course, it wasn't being reimbursed, but now with 5G, incredible technology in the home that can do a lot with RPM. Next slide. Just a few more things of RPM in the news. Again, I put these in just for future references. You get a copy of these slides. I want to draw attention to the last one. Venture capital may be slowing. At the most recent American Telemedicine Association meeting in December, there were a few speakers. Venture capital has been heavily brought into this field. As you saw, the amount of money projected to be invested in RPM is getting a lot of people's attention in venture capital. But there were a couple of speakers at the ATA conference noting that things are going to slow down and the money is not going to be quite as available as it was during the pandemic. So just a slight caution, a large wearable device maker has filed for bankruptcy, and there's going to be consolidation in the industry as we move forward, but it's not quite as free-flowing in terms of funds, which we had to do for COVID. But as we figure out what telehealth will be preserved permanently, there will be some decrease in this field. So just a slight note of caution. Venture capital can't support it forever. Next slide. So another important thing to recognize is RPM and RTM, which are important terms for Medicare purposes. RPM codes were heavily introduced in the physician fee schedule in 2019, although the first RPM code was in 2002. It wasn't particularly heavily used, but just in time for COVID, CMS moved into RPM billing codes and made it reimbursable. Then in 2022, they introduced RTM, remote therapeutic monitoring, and it is different than RPM. And it's important to understand those distinctions. RPM is monitoring physiological data. RTM is monitoring the non-physiological data therapy, and it does not involve electrodes on the skin, for example. So those are billed differently. They're very similar, but they're different sorts of things. And even the rules for what is reimbursable are different in terms of, is it direct supervision or is it general supervision of practitioners, and which practitioners can do this. So it's really important to understand the distinctions that Medicare is drawing. I can't tell you whether the Medicaid programs are doing that or not. What I would say is it is important, if you're brand new to this area, to find someone in your hospital, in your clinic that is, I want to say consult counsel, because there are ways you can mess this up and not be reimbursed for what you thought was reimbursable because you didn't quite follow the way CMS has laid this out. Next slide. So in addition to RPM and RTM, there's also chronic care management, CCM and PCM, also chronic care management. PCM is one complex condition. CCM is if there are multiple complex conditions, and they all have their own billing codes and their own rules, but these are all largely talked about as RPM, but in fact, they are distinctions that CMS has made that you have to understand to know how these things become billable. Next slide. I was on that slide. In the next, in just a minute, I'll have another slide. I should issue a disclaimer. As a Fed, we are, as I said, we are not the agency that funds this stuff. That's CMS. So anything that I may have misrepresented in terms of billing, do not take my advice as the correct way to do it. This is just for discussion. If you need to know the rules, and you do, go to CMS. If you have trouble understanding the rules, call our telehealth resource centers, because that's exactly what they're there for, and they can help consult you to understand how some of these billing codes work. RPM billing guides are fairly plentiful on the internet as I searched, and some of them are pretty useful, and I'm not saying any particular one, but doing some reading on the coding is really helpful to understand what you're getting into. Next slide. So I then look for, is there a nice table of all RPM codes, RTM codes out there, and sort of what they are and what they on average may pay. And I couldn't find a really good table, so I started assembling one. And this in particular, I want to say is for a discussion item only. Don't take what it says here as the gospel and say, CMS, why didn't you fund this? Because Bill said this was fundable. That's absolutely not the case. Check with your TRC, check with your counsel, but these are RPM codes, and there's a setup code, a monitoring code, which emphasizes you need to monitor at least 16 days per month to submit for this code. Then there are codes for treatment management, the provider reviewing the data that's coming in and consulting with the patient for 20 minutes or an additional 20-minute code to discuss what am I seeing in your data and how does that affect your treatment. And then what I characterize as the original RPM code 99091 created in 2002, but it didn't really get into heavy use until just recently. Next slide. And then some other codes, as I mentioned, there are other things that are monitoring codes that should be looked at, and they're for specific areas like blood pressure monitoring. Next slide. And then the RTM codes. So the RPM codes came in the physician fee schedule in 2019. RTM was introduced heavily in 2022, and they look a lot like our PM codes, but these are for specific systems, and the RTM codes are for respiratory or musculoskeletal. Outside of those areas, you can't do RTM. RPM devices have to submit their data automatically. It can't be the patient reads their blood pressure, types it into a text message and sends it in. That's not a billable RPM device. RTM does allow patient interaction because these are not physiological measurements, and these may require patients to, say, how do you feel today? What has been your adherence to your treatment regimen? And these are things that you can't measure with the skin sensor. So it looks very similar, but it's a different kind of information. And again, codes for practitioners taking this information and interacting with patients and the amount of time they spend on that. The last one that's on here is kind of interesting. Cognitive behavioral therapy, again, needs to be monitored at least 16 days, but the pricing for that is to be priced not by CMS, by national, but by the MACs. And that's basically because CMS didn't quite know how much these things should be priced. So it's kind of experimental, and the regional contractors will determine their own price. So that's when we don't exactly know how much you're going to get. It's going to be something you're going to have to find out, ask as you submit claims and CMS will be studying that and will come up, I'm sure, with reimbursement codes or amounts soon, but not for 2023. Next slide. So there was expected to be a big change in RTM for 2023 physician fee schedule. In the draft physician fee schedule published last summer, these codes, these 4 new codes occurred. These were going to expand practitioners that could bill for RTM. But in the final schedule that was released in November, because of all the feedback that CMS got, they basically decided we don't have enough information yet to put these new codes in. So they went back and said, we're not introducing these new codes, which basically means we have the 2022 codes are still the law of the land for Medicare purposes. But they did make a change in which these codes were going to do in terms of the direct supervision versus general supervision requirements of billing these codes, and the staff, the health staff that are able to perform the services under the supervision of an appropriate practitioner, if you will. So again, it gets a little bit technical, and this is why you really do need to consult with counsel or someone, and maybe it's our TRCs on some of these details. Next slide. And then pain management codes, which again are not really RPM, but are in the general area of. And then what's really interesting, and some people thought CMS might come out with home health codes for RTM, RPM, I guess it'd be RPM for most likely for them. So CMS created 3 new codes. They're optional for the first 6 months, mandatory for home health to submit in as of July 1st, but these are not reimbursed codes. These are information collecting codes that CMS wants to know from home health agencies who are administering RPM devices and meeting with patients and leaving technology at the home, which is not being reimbursed, except as the home health services are reimbursed generally, but not specifically for this. But CMS wants to know what's going on out there, and conceivably they will be creating reimbursable codes for this in the future. So again, huge growth area, and that's why the industry is very excited. A lot going on in this space, and it's great. It's great. We have electronic house calls, and now we have the ability to have much better data, clinical quality data being submitted, not just because I had an unfortunate event, but my doctor now has some history of my heart condition, not just the last week. Next slide. I think that may be about it. Oh, FDA. FDA, of course, is very involved in these devices. So for the pandemic, the FDA arguably relaxed their requirements and allowed devices to be or manufacturers to do some things that possibly would have required a complete re-review by the FDA, recognizing it's really important to keep this stuff going and to allow patients to be submitting information data from home. But that's something that will not continue beyond the end of the pandemic. And they put a guidance out on it in June saying, here's what the rules are for the emergency. But FDA, very important entity. If anyone on this call is a manufacturer, I'm sure you're aware, you can very easily get into an area where your devices, if they're clinical presenting data, will need to be FDA cleared. Next slide. And then even the concept of software may become a device. So the FDA has guidance of when does software become a device? And that's important because things like AI can morph over time. And those are, as we get terabytes of data coming in from patients, providers can't begin to understand all this. So it's kind of important to pre-process through software some of the information that's coming in, and even using software that can change as it recognizes things going on and patterns, et cetera. So at some point that software is essentially a medical device that will require FDA approval, even though it's just pure software. Next slide. And then OIG has also gotten kind of interested in this because people are getting these devices at home. The FCC surprisingly had one of their COVID programs, an entity said they're going to hand out 3,000 smartphones to all of their patients using FCC funds. And that healthcare provider said, by the way, would that be a Stark violation? Because those devices can only connect to me. And in fact, the OIG basically said, yes, it would be a Stark violation, but you're doing it on the auspices of a federal agency, so it's okay. And that's important. It would have been much more problematic. They said it's not okay, but that doesn't necessarily mean that you could do this outside of a federal program. So just again, another agency to be aware of is OIG is watching this to make sure that we don't abuse and use RPM as a tool to bring people into the hospital. Next slide. And I think that's it. So that's my contact information. And again, I went through stuff really fast. You'll have these slides and you can look up some of the references that I really couldn't dive into. So thank you.
Thank you so much, William. That was a great presentation. Of course, here is HRSA's information, so you can go ahead and learn more there. Sign up for their newsletter, has some really awesome information. And now we're going to open up the floor to some questions if anyone has any for William or just anything in general before our next session. So go ahead, you can chat it in, you can come off mute if you would like, or you can use the Q&A. Give it a few seconds there for any questions. Alrighty, and then yeah, if you guys could take a second to fill out our poll, that would be very helpful. It lets us know where to improve, all that fun stuff. And it looks like we do have one question from Anne. saying, who funds your organization? And I'm assuming who funds HRSA is the question.
Yeah, I'm guessing that would be it. So we get
Yes,
an
okay.
appropriation every year from HHS gets an appropriation from Congress, and we get an appropriation for our office. I think it increased about 3 million this year. I didn't include a slide. So I think our total budget this year is maybe 35-ish million. And it's been increasing 5-10% every year. And we had some significant COVID funds, as did many HHS and other aspects of the government, and those have ended. So that's where, again, we don't have a lot of new money that we can use. We're back to sort of the normal programs that we run. We have 9 different grant programs that we're currently funding, but not an opportunity to add any new ones. All of our programs are congressionally approved, mandated, if you will. We don't get, free money that we can do anything we want. We fund programs that Congress has indicated there's an interest in us funding.
Thank you, William. Another question on the regulatory environment in regards to FQHCs being able to bill Medicare for RPM, RTM. If you have any insight on that, William?
Yeah, I thought that question might come in. I was trying to sort of research to be able to make a well-informed statement on that, and unfortunately, I don't want to wade in on that. The billing codes for federally qualified health centers are a bit different, as I think many of you on the call are quite aware. So what I was talking about were the fee-for-service codes, and I just didn't get a chance to dive into where we are with FQHCs. So hopefully some of our other speakers, who I think at least one is from an FQHC, can maybe talk about that. But we are very aware that FQHCs, health centers, from our perspective, this is a great area for them to be in serving their 30 million patients. So yeah, stay tuned. This is a growth area.
Absolutely. Alrighty, we do have a couple other questions. Looks like one about on reimbursement, but we are about to have our policy panel. You are going to be able to talk to a really great team of experts and a lot more. So hopefully some of your guys' questions will be answered. Bill doesn't have all the answers, unfortunately, even though he's a very great and smart guy. But right